Hey, welcome to Not So Complicated, and today we are starting a new series and WTF series that is, and it is what you think it is. So, episode 1 is Paradoxical Embolism. So, in Paradoxical Embolism, the overview is that it is confusing because it defies typical embolism rules, crossing from venous to arterial circulation. We'll talk about definition, pathophysiology, clinical scenarios, diagnosis, treatment, and examples, right? So, definition and pathophysiology. So what the is paradoxical embolism? So it is normally what happens is emboli starts in veins, example in deep venous thrombosis, and travel to lungs causing pulmonary embolism, and this is the Birkhoff triad right here. So venous like immobility, and then paralysis, atrial fibrillation, and congestive heart failure, and hypercoagulable state like malignancy, pregnancy, protein C and S deficiency, and thrombin deficiency, and basal wall inflammation like indwelling catheters, trauma, and surgery. These all are very much prone to develop embolism, right? So thrombus actually, and that thrombus gets dislodged and that becomes embolus, right? So this is the normal route, but in paradoxical embolism what actually happens is that a venous clot sneaks into the arterial circulation causing strokes or limb ischemia. How? So through a right to left shunt, usually a patent foramen ovale, an atrial septal defect, or rarely a ventricular septal defect. So what actually happens in normal case is that the clot passes from right atrium to right ventricle, then it passes to the lungs and there become pulmonary embolism, right? But what happens in this case is that the clot passes from right atrium to left atrium via the patent foramen ovale PFO or ASD, and from left atrium to left ventricle, and from left ventricle to the systemic arterial circulation. So that is how it is causing paradoxical embolism. So here is the step-by-step thing. A clot forms in a vein, example leg DVT. It dislodges, travels to the right heart. Instead of hitting the lungs, it passes through a PFO, a flap-like opening between atria, present in 25% of people due to elevated right heart pressure from pulmonary embolism or pulmonary hypertension, right? So the clot enters the left heart, then systemic arteries hitting brain where it causes stroke, and heart if it causes MI, that is myocardial infarction, or limbs that causes acute ischemia. So USMLE poll for this is that patent foramen ovale is often asymptomatic until a paradoxical embolism occurs, making it a silent culprit, right? So clinical scenarios, picture this. A 35-year-old woman with leg swelling DVT suddenly has a stroke. No atrial fibrillation, no carotid stenosis is there, so we have to suspect paradoxical embolism. The common presentations are stroke in young patients, that is less than 50 years, with DVT or PE, and acute limb ischemia, that is sudden leg pain, pallor or pulselessness, and in myocardial infarction, which is rare but it mimics coronary artery disease. So the risk factors are deep vein thrombosis, recent immobilization like surgery, lung flights, pregnancy, oral contraceptives, pulmonary hypertension, or Valsalva maneuvers that increases right heart pressure, right? So the USMLE poll for this clinical scenario is that we have to look for a patient with DVT, PE, and a systemic embolic event. Paradoxical embolism is the answer. So how do we diagnose? Diagnosing paradoxical embolism is tough. Here is how we nail it. We have to suspect it first. Like if a patient is young with stroke, limb ischemia, or MI plus DVT or PE history, so we have to suspect it. And in imaging, we have to do the imaging for emboli. Venous imaging is usually done by Doppler ultrasound for DVT, leg veins, and pulmonary imaging is by CT pulmonary angiography for PE, and also systemic by brain CT or MRI for stroke, CT angiography for limb ischemia. So now we have to find the shunt, where the shunt is, PFO or ASD, right? So transesophageal echocardiography is done, which is gold standard to visualize PFO or ASD. So it's right to left bubble passes, right? In transthoracic echo with bubble study, which is less sensitive but common, and in transcranial Doppler detects bubbles in cerebral arteries. So step 4 is that we have to rule out other causes like atrial fibrillation via ECG, carotid stenosis via Doppler, and hypercoagulable states like protein C, S, factor B laden. We can screen that, right? So what is the treatment and prevention of this disease? Is that in acute treatment we have to use anticoagulation. We have to do anticoagulants like heparin, that is acute, warfarin or DOACs for long term to prevent further clots, and thrombolytics for massive PE, that is pulmonary embolism or severe limb ischemia, example alteplase. And embolectomy should be done, that is surgical removal for large arterial clots. The long term treatment is that we have to close the sound, right? Patent foramen oval, percutaneous device like Emplazer for recurrent emboli or high risk PFO, controversial, that is trials. This is just a trials case, and some benefit only in select cases, and anticoagulation like a lifelong if hypercoagulable or persistent DVT risk is there. So the prevention, we have to do the DVT prophylaxis, example heparin for hospitalized patients, avoid Valsalva in patent foramen oval patients, and patent foramen oval closure isn't routine. Anticoagulation is first line unless recurrent events happen. So that is all for today. Subscribe for daily what the fucks. Thank you for staying with me. Thank you.